So this is a very complex pathway here, but these are all of the molecules and potentially some of the antibodies and other therapies that are being looked at for trying to enhance these pathways. And they're probably going to be able to work together in some fashion. Now, obviously, we don't have all the information yet to know this, but we want to try to probably enhance the PD-1 pathway in addition to using some of these antibodies or other ways to improve the co-stimulatory molecules by enhancing them together. So lots of different potential combinations, and what works in the laboratory in animals or in test tubes doesn't always work in patients. So obviously we have to take these to clinical trials eventually when the theoretical idea is there. So the other area that we're probably going to be seeing a lot of is combinations. So probably the PD-1 or PD-L1 antibodies are going to be combined with many of these different types of pathway agents or antibodies. And there's just a plethora of different clinical trials out there in combinations of these together. Again, we don't know which is best. I think theoretically, probably the PD-1 with an BTK inhibitor is probably going to be very interesting, but there's a lot of different other possibilities that you can see on this slide. So just switching a little bit to some conjugated antibodies. These are a little bit less as far as development, but of course we have the brentuximab, for example, been available now for several years. And there's some other conjugated antibodies out there that look sort of interesting. Next slide. So these are the conjugated antibodies that are a little bit further along in some of the information here. So brentuximab has been available for quite a long time for Hodgkin's or anaplastic large cell. You can see a list of some of the other antibodies, and I'll just say that they kind of differ by some of the different linkers they have, by the target antigen. A lot of CD22, CD19, there's CD37. And the cytotoxin that they deliver, you can see is a little bit different here too. So a lot of the side effects from these come from the cytotoxin that's delivered. And so we have to make sure that the linker is good so that it's not released before it goes endocytosed into the cell. And those are some of the different things that they're looking at, trying to make sure that there's different types of linkers that are going to be able to work for this. So a lot of interest here. I think probably we'll be hearing more about the polatuzumab is one that looks kind of interesting in phase 2 studies, and that's being put forward. And some of the other ones are a little bit less further along there. Next slide. So you can see on this slide some of the efficacy that have been shown in different clinical trials in different types of lymphomas. Most of these have been tested in relapsed diffuse large B-cell lymphoma for the most part. And there are some that have some good activity for diffuse large cell and also follicular lymphoma. Lots of different clinical trials that are going to be ongoing. I'm sure we'll hear some new ones this year as well. Just switching a little bit to some of the pathway agents. We're all familiar with the BTK inhibitor ibrutinib. It's been available now for a couple of years for patients with CLL and mantle cell lymphoma, and most recently Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma. There's also several others that are in clinical trials. On this slide here, you can see that the different agents that are in development and the mechanism. They differ by mechanism in that some are reversible, some are irreversible. And they're also trying to look at different potential combinations with some of these agents as well. You know, potentially these agents have a slightly different target on the BTK, and this may be optimum in different types of diseases or based upon what mutations the patient has. Some of these may work in patients that have mutations in the BTK that make them resistant to ibrutinib. So those are kind of unknown at this point, but lots of clinical trials going on. Next slide. So ibrutinib, I think you're probably familiar with, had a phase 1 study where it looked at a number of different types of lymphomas, and this is from that original study, where it demonstrated really great responses for patients with CLL, mantle cell, and some patients with diffuse large B-cell lymphoma. Did not seem to work quite as well in follicular lymphoma, but it has some activity. And you can see that this is from the original study. So 85%, 41 out of 48 patients responded in that original study with some decrease in their lymphadenopathy. Next slide. Now it's kind of gone on to a number of different trials that I'm sure you're familiar with as far as, this is just one example for patients with CLL, looking at the Resonate study, which was ibrutinib versus ofatumumab for patients with recurrent CLL, and the Helios study, which was ibrutinib, bendamustine rituxan versus placebo bendamustine rituxan for patients with recurrent CLL. And you can see the results there were quite good in both of those populations. Next slide. So mantle cell has always been a difficult lymphoma to treat, and for patients who take BTK inhibitors, specifically ibrutinib, and have a response to it, they often have a response that goes on for a number of years, actually. And you can see the very high response rate here in this study. This was published in New England Journal in 2013. So the complete response rate was about 20%, but overall response rate was almost 70%. And the patients had a very long duration, particularly if they went into complete remission. Unfortunately, not everybody responds to this, and there are some patients that have mutations that make them resistant to this. But for many patients for mantle cell, it was really a drug that really was beneficial. Next slide. Also interestingly, diffuse large B-cell lymphoma, there's a subset of the patients that respond to ibrutinib, and this was presented by Wyndham Wilson. We actually participated in this trial as well. And it's just going to be coming out in publication in the next couple months. I think it's available online now. So patients with diffuse large B-cell lymphoma responded. Some responded really well, others did not. And we did a lot of work to try to figure out who responded. And what happened was when we did the subset analysis, it appeared that almost all the patients who responded had the activated B-cell type of diffuse large B-cell lymphoma. And patients with germinal center B-cell type did not respond very well, and this has been confirmed in further studies. So this may be another subtyping that we want to do when considering these medications. Now, ibrutinib is not currently approved for this indication, but I think they're going to be trying to get that approval probably over the next year. And it's probably another thing we want to try to hone down on the patients who are going to be able to respond to these treatments so that we don't use them in patients who we know aren't going to respond. Next slide. So ibrutinib is very active. It does have some side effects. Atrial fibrillation can be exacerbated in some patients, and there's some bleeding tendencies that relate to some activity against some platelet antigens. But for the most part, it's pretty well tolerated. The challenges are we need to probably combine this with chemotherapy, and it's been done in a number of trials now, but we don't really know the optimal combination. And we're probably going to want to target this and combine this with other therapies as well to enhance the pathway suppression, not only from one side, the BTK side, but from other sides as well. So we're probably going to be seeing a lot more about combinations of different pathway agents over the next few years. So another pathway that's in that same B-cell pathway is the PI3 kinase pathway. And currently we have the idelalisib, which is a PI3 kinase delta inhibitor. There's a number of different inhibitors also in clinical trials that are listed on this slide. And the approved indication currently for idelalisib is recurrent follicular small lymphocytic or other indolent lymphomas. Again, for those patients who responded, had a really great response. About between 50 and 70% of patients in the early studies responded to this with recurrent indolent lymphoma or CLL. So this is from one of the studies with idelalisib plus Rituxan versus Rituxan alone, basically for patients with recurrent CLL. These were patients who could not otherwise receive aggressive treatment, older patients typically. And you can see that there was quite a marked improvement in overall response rate compared to Rituxan alone. And for patients, this is from one of the original trials looking at the different types of lymphomas, follicular, small lymphocytic, marginal zone, or lymphoplasmacytic, that a number of different patients responded as far as decreasing tumor size and some very good partial and complete responses. So it has activity in a number of different patient populations. So in addition to that, which is currently available, there's also other ones that are being looked at, and I'm just going to go over a couple of those. So ublituximab is a different type of anti-CD20 antibody that targets a different binding site. Potentially could be helpful in, it's a glycoengineered one. It's potentially helpful in patients that have low CD20 activity, and that's also in some clinical trials. Next slide. The reason I show that is it's in clinical trials with this different PI3 kinase delta inhibitor, TGR-1202. And this profile is a little bit different than idelalisib. It's a once-a-day dosing instead of twice a day, and appears not to have any hepatotoxicity. So, next slide. So this is kind of one where you have to keep going. There's a bunch of stuff on there. Yeah. So this, that's good. This particular trial, pretty complicated, but for patients with non-Hodgkin's and CLL, a bunch of different cohorts at different dosing levels. And the patients receive a combination of the intravenous ublituximab and the oral PI3 kinase delta inhibitor. And this has been presented now at ASH and at Lugano a couple weeks ago, and really looked very interesting for some of the multiple recurrent patients with different types of lymphoma, even diffuse large B-cell, CLL, and indolent lymphoma. Next slide. This was kind of from very early studies looking at this combination, and patients with diffuse large B-cell, with even one patient with Richter's transformation, and some patients with follicular responded quite well to this, and 78% of the follicular patients had not had progression at the time this was presented. Next slide. So very early in the looking at this, but appears to be kind of promising. This was just presented at the Lugano meeting, also at ASCO this year, where they actually combined 3 drugs together. So the TGR, PI3 kinase delta, ublituximab, anti-CD20, plus ibrutinib, and found some really good responses for these patients, but very early on, and we don't know what the long-term outlook is on this. But suppressing the B-cell pathway plus an anti-CD20 appears to be quite promising in suppressing the B cells. Next slide.